Got it. I was saying
Got it. Okay.
got me doing my first podcast on a under desk treadmill, so don't confuse me from Michael Greger. Now it's your show.
Yeah, good for you. Good for you. Like I said, I'm standing, and I encourage, like I said, I try to encourage people to avoid, as much as possible being too sedentary. So it just makes it easy to, stand when you can instead of sitting, and walk instead of standing if you can. So it makes sense. So good to see you doing that. First of all, Joel, thanks for doing this. Appreciate. I apologize. Last Sunday I had to go out of town unexpectedly, kind of, and we had to reschedule. But anyway, I'm glad to have you here.
I am your #1 vegan fan, so don't you worry.
Hey, are you still in? You're still in Michigan, is that right? Are you still in Detroit?
I'm in my office right now, Bingham Farms, Michigan, suburban Detroit, and live around here. Daughter now lives downtown, so getting downtown a little bit more, and such an exciting life. I grew up 1 mile from where my office is, so not very far in terms of adventure,
nice.
adventuresome activity.
We just moved up to Washington State. We're out in a kind of a rural area still, so it's a little change from California out to here, so it's kind of nice. Well, I wanted to, like I said, obviously you and I have different sort of dietary beliefs in we have some opposition beliefs on that. I think we both think that most of the processed food that's out there is probably not ideal for us. I think it's fair to say. I certainly appreciate your cardiologist perspective, and that may be something. But I think importantly, we've got people coming together, and I see some of the stuff you're putting on social media very similar to mine. And I know this is a topic that it's tough to talk about these days, but there seems to be a censorship of physicians, a restriction of freedoms, in many ways. I mean, I personally am just surprised how many physicians are willing to just not say anything at this point. And I applaud you for having the courage to say something. I mean, I know it puts you at personal risk. But to me, it's worth it. And I know getting too specific into stuff gets you censored and shut down, but are you a little frustrated with what's going on recently, just in general terms?
Sure. I still have a very active practice, 31st, 32nd year of medicine. I don't do as much academic stuff as I used to. I used to do research, write papers, go to national meetings. But I understand pretty much how the medical world and the scientific world works. And it's discussion, it's debate. I mean, it's carnivore versus Mediterranean versus vegan. We could be on a panel, we can discuss. They're not going to, take it down just because it's at Paleo FX or at something similar that's more from a plant slant. I mean, this is how it used to happen. I mean, national TV shows and medical conferences. I mean, I wrote a paper, a debate, stent versus balloon, back in about 2002 against another cardiologist. Debate has always been like the hottest topic at the national meetings. But I swore to my wife in early 2020, I'm a cardiologist. I don't need to jump into the COVID world. I got a zillion requests from certain people to do a quick interview locally or nationally. I turned them all down. And I really didn't spend that much time studying it until the late part of 2020. And I just started seeing some of my peers speak up. Peter McCullough, MD, a cardiologist I actually helped train. He was trained at Beaumont Hospital where I was his attending. Pierre Corey, Paul Merrick, very prominent pulmonary doc, speaking out. And I just got caught up watching Senate testimony, a couple YouTubes. And unfortunately, you're a contrarian. I mean, you're not saying the same thing as every other trained orthopedic surgeon. I'm a contrarian. I'm not saying that, and I've been doing that for decades. And it's been ostracizing, and it's been, occasionally disappointing, demoralizing. My peers eating, fried chicken sandwiches in the doctor's dining room and French fries, knowing better. But it wasn't shut down. And it's what you say and what's going on. You're getting shadow banned. I get shadow banned. I get stuff on LinkedIn taken down. And it's peer-reviewed, articles. That's what's shocking. So yeah, I'm totally on board with you. I'm disappointed, but I get it too, because most of what's going on is mass psychology. It's repetition. If all you do is open the New York Times and turn on CNN, MSNBC, or maybe your hospital email, you're going to have a very strong view of the world. It's very different from a broad, platter of tasting various different opinions, including scientific. We're not talking, let's go to the darkest conspiracy side. Let's go to PubMed.gov, and I'll tell you right now names of some articles you should read, all you doctors listening, but you're probably already more open-minded than most if you're watching this, listening to this. But yeah, it's disappointing. I'll give you one last example and I'm done. I got a text message 2 days ago from a pulmonologist at one of the Beaumont hospitals. I knew him for years. I haven't seen him probably for 5 years. Very pleasant man. Didn't know he had any opinion on what I was saying on social media, but not exactly surprised because my social media is pretty big like yours. And he texted me an article from Forbes about how ivermectin is a joke and a scam. And it's pretty clear that was a pharmaceutical bought article, as you can do. You can influence. There's lots of money they have to choose their writers. And I answered back. I said, you need to look at a website, www.ivmmeta.com, ivmmeta.com, which is all the articles on ivermectin. There's 64 of them. About 32 are randomized clinical trials. I said, you need to understand this is always multi-drug, multi-nutrient therapy. It's not sinus infection amoxicillin. This is much tougher. It's 6-7 treatments. And I said, what do you offer your patients when they call you and tell you they're sick with COVID at home? Do you follow the CDC, which says oxygen and mechanical ventilation? Because I looked at their website last week, and that's what they mentioned for therapy of COVID-19. And now it's expanded to monoclonal antibodies as an outpatient and remdesivir as an inpatient. And so that what you offer, and not in a contentious way, but why did he text me? Because it's an ugly world, and there's what I would consider a tremendous amount of misinformation from the standard medical world, denying patients opportunities, and and it's dangerous, like you said. I worry a little bit about speaking out, but you can't live your life as a full human and live it in an intimidated way. That just doesn't jive with my personality, and obviously not with yours.
Yeah, I mean, I was at a birthday party last night, and a bunch of, I guess, people that feel pretty strongly about personal freedoms, and they talk about people saying, well, I'm just going to go move out to the country, out to Montana and stuff like that. And I think by doing that, I mean, you just kick it down the curb 10 years. I mean, it's just like you can't run from this. This is something you have to stand and speak about where you are now, and not do that no matter what the situation is. I wanted to ask you, just while we're on this topic, we see quite a bit of information coming out about pericarditis, myocarditis. Obviously, as a cardiologist, that's within your purview, although probably it's not the major part of your practice. What traditionally causes that, and what is because we keep hearing, it's not really a big deal. Most get it, people that have it, they're going to be fine and don't worry about it. Is that what you feel, or what are your thoughts on that?
Yeah, so myocardium is a fancy word for heart muscle. Myocarditis is an inflammation or an immune attack to the heart muscle. And pericardium is a lining around the heart filled with fluid. So pericarditis is an inflammation around the heart. Most commonly, they're both of unknown cause. We suspect viruses, something called the Coxsackie virus, classically echovirus, not so much the common flu or cold. And you can get some chest pain and shortness of breath. You could develop congestive heart failure, really, getting swollen, unable to lie flat, irregular heartbeats, and rarely it can go on and be serious and even death. That's the usual course. There's very little we can do but support the heart. Oxygen, medications, could be hospitalization. Most people recover. Some people are left with some heart damage. Some people die. A bad case of myocarditis. And pericarditis can be recurrent. You can have it once, really hurt, resolve, and come back. A little bit like long haul COVID, but there's periods in between. The classic drug, interestingly, for recurrent pericarditis is colchicine, a gout drug repurposed to be used worldwide for the heart. And nobody argues about using a repurposed gout drug for heart disease. Interestingly, there's at least 2 major trials of colchicine in COVID because of its powerful anti-inflammatory aspects, and it's very inexpensive, something that I will use both in cardiac patients and COVID patients more commonly. And then we saw cases, there are clearly cases of COVID-related pericarditis and myocarditis. I've seen 2 pretty dramatic ones in my clinic after they were discharged in the hospital. And that's a serious disorder, there's no doubt. But, not completely unexpected. There's a document from the FDA in October 2020 listing possible problems with mRNA vaccines should they be fully released, which of course happened mid-December 2020. And myocarditis and pericarditis were on the list as anticipated problems. But it was rarely seen till early 2021. The Israelis reported a few cases. And the CDC has had a couple very rare news conferences on myocarditis, pericarditis, post-COVID, post-vaccination, and a few hundred cases. But just to circle back, just last week in the New England Journal of Medicine, used to be a pretty prestigious journal, but they certainly trip up and are faltering in the COVID era with some false publications had to be retracted. There were 2 big studies in Israel of vaccine-related myocarditis. That's going to be 100% Pfizer because that's all Israel gives. And the numbers per 100 million were higher than what the CDC identifies. That was the headline even today at MedPage today. It's still maybe lower than COVID-related myocarditis. That's a great debate. But the thing is, what's the risk of a 24-year-old college student, or Kyrie Irving, who's resisting the vaccine and making a lot of headlines right now, I believe with the Boston Celtics. I'm not the biggest sports nut. What's the risk of getting a COVID episode? Nobody wants to get COVID. And there's clearly a risk of a severe illness and a long haul illness. But in general, a 24-year-old athlete who's eating halfway decent on some nutritional support with COVID, it's going to be over in 3 days. It's like the flu, maybe less in general, not always. But what's the possibility of taking an asymptomatic athlete and developing myocarditis? Usually it's within 1 week of the second vaccination, the second Moderna, and of course Sweden and I think it's Denmark just banned Moderna in men under 30 because they made a judgment the disease is too mild and the risk, whatever it is unacceptable, because there have been deaths from myocarditis related to vaccination. There have been many hospitalizations, and there have been episodes of permanent or seemingly permanent congestive heart failure. Just finally, today, there is a website that all your listeners should familiarize with, even though it has its flaws. It's called OpenVAERS, OpenVAERS.com. It's an analysis of the CDC NIH database that comes out about every 10 days. So they are up to 6,800 reported cases of myocarditis, pericarditis in the United States through October 1, way more than the few hundred the CDC has reported. Now, these are physician-reported, nurse-reported, self-reported episodes. Traditionally, they all have to be reviewed by some committee at the CDC, NIH. And I'm saying NIH, I think it's CDC and NIH. It's 2 of the institutions. There's so many cases. There's actually now 750,000 reports in the first 9 months of the vaccination, which is just about how many there were in 30 years for all other 70 vaccines. So it's blowing away the agency's ability to look at these reports case by case and verify or not verify. And they're reported to be just completely behind schedule. So even these numbers may be far off, but that's the ethical issue. Minor disease for almost all, survival rate 99.98 for a 24-year-old male, and the potential to ruin a career or at least delay a career because of a long recovery, because you're going to have a hard time releasing an athlete who develops myocarditis, symptomatic, hospitalized, back to professional sports without major limitation. They may be out forever. So that's why you see a couple of these really headline athletes resisting both in college and in professional sports. Tough one, because again, it's symptomatic care. We don't have a quick cure for myocarditis. It's destroying your heart muscle. It always leaves scar. And you just don't know. You're 24 years old and there's some scar in your heart, even though you're recovered. Is that ventricular tachycardia when you're 46? I mean, we don't know, but nobody volunteers for myocarditis. Just like nobody should volunteer for SARS-CoV-2, but it's spreading through the community, creating natural immunity all over the place. While we're debating whether 5-year-olds should get vaccinated, it's happening without the vaccine.
Yeah, that's that point that you bring up about, the young healthy person. And so, I mean, are you still tied to hospitals, Joel? Do you do some inpatient hospital stuff? Are you still in the hospitals here and there?
I'm on staff at one of the largest hospitals in the United States, William Beaumont Hospital, Royal Oak, Michigan, about 5 miles from my office. Been on staff 28 years. I don't routinely make rounds unless it's one of my clinic patients that ends up there. And I have a pretty healthy population, so that happens pretty rarely. I pass them off, hand selected. And, they're not happy with me, as I see from that text message I got from my pulmonology colleague. I'm not particularly happy with them. It's nearly impossible to get any innovative care in the step down or ICU for a patient with this virus right now. It's support, steroids, remdesivir, which was a drug tried in Ebola virus pretty unsuccessfully, but repurposed at many $1,000s a dose for hospitalized patients. Now they're trying to get it approved for outpatients because it'll expand the market tremendously and financially. Very unclear if it's a safe drug or not. Some of my patients have read the literature and refused to get it in the ICU. Totally frustrating. The staff, a big VA randomized study of remdesivir showed it did nothing for mortality. One time big, like 2,400 patients with serious SARS-CoV-2 hospitalized. It did nothing for mortality. It extended the hospitalization by 4 days. And that is the official approved inpatient drug other than steroids. The other thing is most steroid doses, there's a randomized trial identifying the benefit from steroids in hospitalized patients with SARS-CoV-2, but the dose was very low. I think it was dexamethasone 6 milligrams, but that's what docs are using because that's what the literature has shown, rather than as Pierre Corey, a pulmonologist who's very often seen and interviewed on social media and who has that website. Again, another one everybody should know. FLCCC.net, which is Frontline Critical Care Coalition.net, and their protocols for inpatient, outpatient, and long-haul COVID care. But rather than using your clinical judgment, saying there's a sick person, we need to blast them with more steroids, because on the inpatient side, that can be helpful to calm the lung inflammation. And then you got to deal with the blood clotting because the blood clotting is tragic and all over the place. But yeah, it's real frustrating to do inpatient. I've had patients bring brownies to their family. This was not my idea. Loaded with vitamin C or ivermectin, or vitamin D or zinc, and sort of the M&Ms of SARS-CoV-2 therapy, based on a lot of good recommendations by people who've published papers. Again, there's something called the Zelenko protocol after a Dr. Zelenko, New York, something called the McCullough protocol after Peter McCullough, the FLCCC protocol, and there's another one called American Association of Physicians and Surgeons Online.org, or AAPSonline.org. They all have really similar and really good protocols for outpatient care. Some of them are so simple. I've got my patients now gargling with betadine, iodine. You put it on, how many surgical wounds before you cut through the skin or whatever, or gargling with hydrogen peroxide and putting it up their nose, because we know that's where the virus likes to hang out. And this data that if you're fully vaccinated people have the potential for a huge volume of asymptomatic virus, which is why I hear from my patients all the time. I went to a wedding, required vaccination. I mean, you're not welcome unvaccinated. And there was an outbreak of COVID cases after the wedding. That stuff has happened around Detroit because of this volume. But if you will take some nasal and oral care for everybody, never vaccinated, had COVID, recovered. That's the best group. Had COVID, recovered is a special place to live right now, but still take precaution. And then finally, even fully vaccinated people, whether they want to wear a mask or not is their own personal choice, but they should take some oral and nasal care because of the asymptomatic carrying phase. They may be carrying it. Don't worry about the other person. Worry about you.
Yeah, that's, I think the Israeli data certainly shows that the folks that have recovered, tend to, it's pretty clear in my view, and it certainly is supported by 100 years of, virology and immunology data that we've had all prior to this. I think except for maybe dengue fever or something like that, most viruses confer pretty long lasting immunity. And I think that's not even controversial. The fact that it's even sort of, kind of argued right now is sort of bizarre to me. Hey, Joel, let me ask you, because you mentioned, Kyrie Irving, and there's other athletes that have kind of spoken out against this, saying I'm not, and I'm aware of some high level athletes that have been vaccinated and now they don't feel like they can perform as well. They feel like
Right.
they're just don't have the, whatever's going on is kind of limited them. When, my understanding, and I'm not making rounds in the hospital, is that the majority of people getting sick are the people that always get sick, the morbidly obese, the people with significant comorbidities, and yet the media is portraying it as, oh no, all these young healthy people are getting it and dying. Is that what you're seeing, or what's going on in the community where you're at?
Well, there is a lot of community-based young people, kids, people in their 20s, 30s getting SARS-CoV-2 for the first time, maybe post fully vaccinated, maybe never vaccinated. They tend to be mild, and you're right. We learned last year very early, obesity, number one predictor of severe COVID illness and hospitalization, followed quickly by diabetes, and then all those other chronic illnesses that are largely lifestyle choices, not completely. It's societal, environmental, toxic, genetic, smokers. And in the era of vaccine, if you look at vaccine breakthrough cases, of which there's tens of thousands for sure, the sick ones fall into the same class, and you've said it, I've said it, good people have said it. We've had 18, 19 months to improve your health. Get a walking treadmill desk, get some Pepsi bottles filled with water, do some curls if if you don't have access to a gym, eat a salad now and then, stop going to Wendy's and McDonald's now and then, drop some weight, do a push-up. We've had all these months, and you've never seen a leader like Francis Collins, Rachel Walensky at the CDC, and of course, Dr. Fauci. Dr. Fauci's never dropped and done 40 push-ups. There has been such an opportunity to attack all the chronic diseases, improve the health of the general population, and it's frankly completely bizarre, and I think it's fairly evil that it's all been on wait till you're so sick we've got questionably effective, expensive, largely inpatient treatments. The exception is the monoclonal antibodies, which are right now exclusively outpatient for the sicker SARS-CoV-2 patient. And, they're extremely expensive, but at least the government has made them available. And I do encourage people, if you fit the criteria, go get monoclonal antibodies at an urgent care center or a hospital. Yeah, we have missed the boat on proper education of the public, because it would have benefited the entire population in terms of, heart risk, diabetes risk, cancer risk. I know the UK has reported a spike in heart attacks and strokes during all of COVID, but actually particularly since vaccination, which is curious for a lot of reasons, but we have not educated those people to lead cleaner lives and get lean and mean like you are.
Joe, my understanding, and maybe the number's up, but I've seen that we spent several $1 trillion on this COVID response, and trillion with a T, which is a lot of money. And, and you and I both promote lifestyle over medication, for whichever way you want to do that. And the opportunity, like you said, the enormous amount of resources that went into messaging, you would have to be living somewhere in the remote woods, devoid of all communications, to not been affected by the messaging of getting a vaccine, social distancing, wearing masks, so on and so forth. If we would have spent, 10% of that money on, hey, let's cut back on ultra processed food. Let's just go for a walk every day, get out and get a little sunshine. I mean, I can't imagine we wouldn't have made an enormous difference. You know, the people talking about, well, it takes too long. I mean, I know that I see people dropping a significant amount of weight, improving glycemic control within weeks in many cases, weeks to a month.
Right.
It's very doable over the time scale we've had. And so what, and you know, someone who has, you know, sort of is a proponent of lifestyle, you know, you're obviously on the plant-based diet side, but there's no funding in that. And if anything, I think this pandemic has put a very, very fine point on the real priorities. They're not necessarily based on getting people healthy. It seems to be, to me, as a skeptic, it seems to be how many drugs can we sell? Does that seem to be the case to you?
I think you're spot on. It's I certainly agree with you. The messaging, I'm listening to music on Pandora and I'm being constantly, you know, reminded to get a vaccine, which is appropriate for some people, at least seemingly in the early part of the vaccination phase. But no messaging. One, if you already had COVID, this message isn't for you. If you've got antibodies or had an illness, that's called natural immunity. And as you alluded to, Israeli data, but actually now 20 studies total, good published studies about the very durable, robust, and complete immunity to a good symptomatic case of SARS-CoV-2 that, you know, anybody overcame. You shouldn't be reckless, but you should be the one with the first and most, like the diamond Vax priority pass, Vax card, if you believe there ever should be cards like that. Those with natural immunity should get it. And yeah, where was that messaging, buying all those ads for any aspect of lifestyle? And it's our government, it's mayors, it's most physicians. I mean, why did physicians, we have had the data, not stand up and say, you know, you need to drop down and do some push-ups and sit-ups and take a counter and stand and do some push-ups on your counter in your office and just set the example. You know, my good buddy, Peter McCullough, cardiologist, who is very well cited in the literature, but also all over various interviews since this whole COVID broke out. I mean, the man was one of the most published cardiologists in the world on hypertension and kidney disease. And he subsequently published more than 45 peer-reviewed articles on SARS-CoV-2. So he's become one of the world's most prominent experts, although mainstream media, you know, despises his message of the failure of medicine to treat people early. But he dropped weight. He saw it coming. He was healthy, but he dropped 20 plus pounds, ate even healthier, went out for even longer runs. And he ended up getting COVID and was pretty sick, but, you know, sailed through it despite some history of hypertension and asthma. And those are all things he says publicly. I'm not his cardiologist, just somebody that I've known forever. I mean, that was a good message, but that was not what CNN and MSNBC and New York Times and Fortune magazine were saying. It still is to this moment, you know, pleading for the next jab, whatever your breakfast, lunch, and dinner were. And you're right. It's, you know, ultimately we can agree 100%. It's the crap that America eats, maybe more than ever, because of lockdowns, because of restaurants shut. You know, in the fast food restaurants stayed open. I mean, you know, if you want to lock down fast food restaurants and leave farmers markets open. Take $1 trillion and give people free food. That, you know, you and I could sit down and create a menu that would be agreeable. Let them pick what they want.
Let me ask Joe, I mean, you know, obviously when this, you know, we're what, 18 months, 19 months into this thing now. When it first came out, there was a lot of unknowns, and, you know, I can see playing it safe. We now have a lot of data that sort of could inform us to just perhaps change, adapt to this. And we kind of sort of doggedly just stay the course, and it's just lock down harder, mask harder, you know, inject more. We're seeing now in places like, I think Justin Trudeau just announced that they spent $60 billion to secure booster shots through 2024, not even knowing the efficacy, knowing the need, knowing the length of this stuff. It seems a bit odd to me. Had you, you know, in retrospect, you know, and we all like to play Monday morning quarterback, but if you could say, okay, let's say we know everything we know now, and we could go back to the beginning of 2020 when this thing sort of broke in. How would you have thought we should have managed this? You know, should we have prioritized certain at-risk populations and done something to them, or should we have had this one-size-fits-all approach, which we seem to apply?
Yeah, you know, I'll do my best to answer, but what we haven't seen at all is a government-endorsed panel of experts. We've had predominantly one expert who's flip-flopped on so many topics that you could make, as has been done, a TikTok about, you know, saying both opinions on a topic that have come over time. And admittedly, sometimes the data changes and flip-flopping your opinion changes, but, you know, lockdown, no lockdown, mask, no mask, schools open, schools closed. We haven't had a panel, and we could have easily had a panel of virologists and public health, and could have had, you know, twice a month updates of consensus as best as can be done. Like happens, there's orthopedic guideline consensus documents. There's many cardiology consensus documents, and these can be done, you know, rapidly and efficiently. They can be done live. We never got that. We never got a data safety monitoring board. I mean, you probably have been involved in some trials of new orthopedic equipment, patient signs of consent. I mean, if it's fallen apart in the first 2 months, there's going to be all kinds of signals, and you're going to shut down that experiment. You know, this is the largest biologic experiment ever in human history. There is not a data safety monitoring board. It's incumbent on the CDC and the FDA to review data, and they have had a few phone calls where they identify no problems with the vaccines. And again, if anybody wonders if there might be problems with the vaccines, you go to openvaers.com, realizing you have to read their declaration of all the limitations of the Vaccine Adverse Event Response System website. You might look up some publications by a PhD in Israel, Jessica Rose, R-O-S-E, or go look for some YouTube. She just testified at the FDA hearing about COVID-19 boosters or not. She gave a powerful 3-minute presentation on the VAERS database, of which she may be the world's expert. You know, so there is no ethics committee. It's just, and, you know, so there's all those problems. One might ask the question, why? Why is this different for a disease that's horrible, but almost all subsets have an extremely high survival rate, although there are also ongoing symptomatic episodes, even if you survive the long haul COVID thing. So, you know, in retrospect, and they didn't ask me my opinion. And honestly, last year I wouldn't have had an opinion. We should have had those committees. We should have had regular public updates for all to see the data. Even today, how does J&J perform compared to Moderna, compared to Pfizer? Fairly important question if you're trying to convince the non-immune, and that is the right term. It's not unvaccinated, it's the non-immune. There are many unvaccinated people that had COVID and they're immune, but the non-immune, they want to go pick a vaccine. You should give them a consumer's report, pros and cons. The data is there, and it does look like Moderna, despite many limitations, may have more durability, but the government only hints at that, doesn't really publish it. So we didn't have the data safety board, the ethics committee, these weekly updates. Early treatment centers. I mean, God bless Governor DeSantis and early monoclonal antibody treatment centers, but there were protocols already available in March 2020, midsummer 2020, fall 2020 in the medical literature, downloaded millions of times. And either a governor or our central government could have instituted early treatment clinics. Even today, I mean, there are an unknown number of doctors in suburban Detroit who, if a patient calls and says, I've got a fever, lost my smell, lost my taste, have chills, rigors, and I just got a PCR test positive, still the majority is, you know, chicken soup, Tylenol, and if you oximeter says 82%, go to the ER. Maybe there's 10 to 20 that will really work with a patient and follow one of these even peer-reviewed protocols. We did a horrible job to date of educating primary care, ER, urgent care docs. Of course, that's why I'm getting texted by a pulmonologist to intimidate me. And is it perfect science? No. Is 64 studies with 32 randomized clinical trials enough to repurpose a drug that won for its researchers the Nobel Prize in Medicine? Is that enough? Is over 200 studies on hydroxychloroquine And there is another site, I think it's hcqmeta.com, that you can look at all those studies easily at one single site. Is that enough? But do we just say until the 10,000 patient perfect randomized study? And what they'll always do is it's a randomized study of one drug, where really what is being done by the experts is called multi-drug sequence therapy. It's many vitamins and many other therapies combined to pull a person through. But I've seen people go from 5 liters nasal cannula at home to 0 oxygen in 12 hours when you apply this kind of approach. It's as gratifying as any other aspect. Fixing a fractured femur, for me, when I was doing interventional cardiology, opening an occluded LAD acutely in the middle of a heart attack, but seeing somebody feel better in 12 hours because they are scared of going to the ER and getting to that horrible ICU. It's as good, and we just need to teach more docs. So, and the sad part is I'm not talking about spring 2020. I'm talking about fall 2021. I don't see any of those things being put in place.
Yeah, it's really a shame, and again, I want to applaud you for having the courage, because I just see a lot of people that I think know this, and I don't know how they go home at night and sleep soundly, knowing that they're just sort of just ignoring these types of things. Let me ask you, Joel, about so informed consent. I mean, as a cardiologist, before you put a stent in someone or do a balloon angiography, there was a document that you asked the patient to sign. You explain the risks, the benefits, to the best of your knowledge, the likelihood, the outcomes, and so on and so forth. Has coercion ever been part of the informed consent process, as far as you know?
Yeah, I can report firsthand. There's an informed consent when you arrive at a hospital sick for any illness, including SARS-CoV-2. Patients have the right to ask for therapy. They have the right to refuse therapy. There are these ugly cases of medical staff berating patients for perhaps not having taken the vaccine. Even some of them, even our COVID recovered immune patients, still being berated. We don't usually yell at people for being smokers. One could argue we should. We don't yell at the obese, which is a very difficult, variety of reasons people are obese. We don't yell at the type 2 diabetic for their diet, if that is a major factor in their type 2 diabetes, but we yell at these people. So yeah, the informed consent process in the hospital is an issue. Yeah, I'm not an expert on informed consent on accepting the vaccine, other than I'd point out a lot of misunderstanding what went on. And I think the date is September 23rd of this year at the FDA approval meeting, because Pfizer was announced, including our president, that it got full FDA approval. And that might reassure somebody who's about to sign that long document. But indeed, all you got to do is go online and read the 4-page FDA document for Pfizer. They got their emergency use authorization of an experimental gene therapy extended. There was no approval of Pfizer fully. That might, reassure somebody signing the consent form that there's been such experience and analysis of the safety that it got full approval. It didn't. What got full approval was a company in Germany called BioNTech that has an agreement with Pfizer. They got approval to make a drug called Comirnaty. You can't find a vial of Comirnaty in the United States because it's not being produced. They got permission, full permission, to produce a vaccine that could be the same as Pfizer, could be different chemically and legally, but they were also required to do studies on myocarditis risk and fertility risk in women as a obligation if they do choose to produce the Comirnaty brand of the vaccine. So there is not a vaccine out now that has full FDA approval. It's all easy documents anybody without having a legal degree can read and look up on the web. And most strangely, 2 senior FDA officials, one of whom signed those documents I just mentioned, resigned 1 week after that meeting and announcement. Nobody knows why, but it's sort of not exactly like going out at the top of your sports career. I mean, these people were intimately involved in these inner decisions, and they're out of the picture. Very, very odd. There's so many unanswered questions, like who's pulling the puppet strings behind so many of these decisions being made.
Yeah, it is, again, as far as, sort of transparency, credibility, and why people might be skeptical, I think there's just ample reason for this when you see stuff like this and you see these, the CDC, well, with the boosters, they just said, 16-2, we do not approve it. And kind of the FDA and CDC kind of overruled that, or sort of just kind of came back and said, we're not going to listen to you. I mean, there was an Alzheimer's drug approved recently. You may have recalled, where I think 12 out of 13 of their advisory panel said no, it's not safe and not effective, and yet the FDA approved it anyway. So there's a lot of sort of conflict of interest at play.
There are the CDC, well, specifically the NIH owns part of the Moderna patent and clearly is known to have a revenue stream. They can't be the safety data monitoring board. They can't both approve under emergency use and evaluate the safety. That's never done in clinical research. It's always an autonomous, independent safety data monitoring board, and there isn't one. It'd be easy to come up with Marty McCary, MD, MPH of Johns Hopkins, outspoken, but very academic and seemingly impartial, and let him put 8 people on a panel and look at these topics. People should read, and everything I've mentioned, 20 papers on natural immunity after a COVID infection. These are in the medical literature. I'm not going to strange websites. That's Jennifer Block in the British Medical Journal 3 weeks ago. And that includes, as you said, the Israeli paper on second infection after a first COVID infection with nearly 700,000 people. I mean, that's amongst those 20 studies. The data on remdesivir extending hospitalization is a VA randomized study that's published in the medical literature. So this isn't any conspiracy talk. It's just you and I seem for now to be able to have an open conversation about this. But your video may well be taken down if I share it on LinkedIn or other venues, which is the new phase of medical community, that the executioner and the judge and the jury are unseen people that just simply have an agenda, and if you cross that agenda, you're out. So you've been banned, I've been banned. Never. It's not that it's been a perfect medical world, perfect research, not that there aren't papers that are retracted, not that there aren't financial conflicts that are exposed, but it's never been 100% censorship as is happening on this topic. And one has to ask why. Why is this different? And the counter answer is, well, it's a national crisis that's ruining our economy, but some would say, go look at Sweden. They didn't ruin their economy and they're wide open, and they had some illness and some death for sure, but they also primarily focused on the high-risk individuals, the elderly, the obese, the diabetic, and they treated the H out of them, and they left young people just to spread this and get it and recover, and seemingly they work pretty well.
Yeah, I've seen like they're ranked 50th in the world now. So they're certainly not at higher risk than majority of countries, as far as COVID deaths total. Let me ask you, Joel.
Look at Israel. I mean, I've been in Israel over 20 times and have great love for that country and the medical community. I've lectured with the medical community and been to conferences and all the history. But, is that an experiment we would conclude has been successful to double vaccinate, triple vaccinate, and now very soon quadruple vaccinate? And yet, the cases just keep flowing and flowing. I mean, these viruses mutate. We knew they would. I mean, they do it in every other viral illness. It's just this virus seems to have mutated more effectively and more rapidly than maybe others expected. And it really didn't start to blast off till the vaccine started to get out and put pressure on that original spike protein from Wuhan. And just a few amino acid changes in the spike protein, and the vaccines are now suddenly only partially effective. Well, they're never 100%, but they were pretty high in those seminal trials of 40,000 people, pretty healthy people too. No COVID deaths in the placebo arm of those trials that got the vaccines approved. So, it was a pretty healthy population being studied, maybe not very representative of who was getting sick in New York and Milan and other big cities like that.
Yeah, they're looking to sort of approve this for the 5-year-old to 11-year-old class, and I guess the study they've done that showed, I mean, the population is so healthy that I think almost no one in that entire trial even got COVID at all, or any symptoms. So it's all they're doing is looking at antibody levels, is assessing the efficacy, which is not a clinical endpoint, obviously. So same sort of thing. Let me ask you, Joe, because we're low on time. I want to get
Sure.
this thought. So let's say you are, you're in a situation, they're going to fire you from your job, and you're going to like, okay, well, I'm just going to suck it up and get the vaccine, even though I don't want to. I'm being coerced to. And you've got this Johnson & Johnson adenovirus vector, and then you've got the the mRNA versions from Moderna and Pfizer. One seems to be pericarditis, myocarditis, and then the other one seems to be a higher risk for clotting. Are there any things you can do to mitigate those things? I mean, I know how to treat blood clots, or at least as an orthopedic surgeon, if I had somebody that's higher risk, I'd at least put them on an aspirin. Is that something that you would sort of say, is that reasonable, or what are your thoughts on that?
Anecdotal, because there isn't a trial, but maybe starting a full aspirin a day before and continuing it for a few weeks after is reasonable, but you're not going to find a paper to support that. There, interestingly, is even in the news today, taking a daily aspirin may reduce your risk of contracting COVID. So there's even another reason to take one anyways, although we've backed away from daily aspirin in the cardiology world for all people. We just use it for stent and heart attack, stroke people, but these are different times. Beyond that, nobody really knows. I mean, I deal with a lot of people very smart in natural health, and they talk about dandelion leaf and pomegranate peel and anything you do for your endothelium. Healthy diet, exercise, that's your inner lining arteries, maybe quercetin, that antioxidant that a lot of people are taking right now, are all good ideas. And not smoking and not eating, Egg McMuffins are all good ideas, but really a protocol to diminish the risk of complications. The only other one maybe in Europe, particularly the UK, and I think to some degree Canada, which I know is not Europe, they often wait 3 months between the two injections for Pfizer and Moderna. It not only allowed more vaccines to go to the rest of the public, but it also seems to improve the effectiveness of the vaccine and maybe reduce the side effects, particularly the young myocarditis cases. Because, when you get that second shot 3 weeks later, your immune system is still really revved up, and that's when the cases are occurring. So maybe that's a better protocol, and there is science behind that.
Why do you think myocarditis is occurring in these young, healthy, particularly males? And I've seen, some recommendations that, particularly ones that exercise a lot, or they should not exercise intently after this. What is the proclivity for young males getting myocarditis? And is that the normal demographic that gets myocarditis?
It's a common demographic for myocarditis. But, I've not read a paper that explains that. There is data that the spike protein of the virus itself damages the inner lining of arteries, the endothelium. There's certainly a suggestion that the spike protein that's created after vaccination may also damage endothelium, although most of the studies are not done post-vaccination. They're done in SARS-CoV-2 patients. But even if you damage your endothelium, that doesn't mean you're damaging your myocardium. So one can only suppose there's some cross-reactivity of some kind between the antibodies raised against the spike protein, which again, for those that don't know, the concept of most vaccines, you get a shot in the arm, the substance stays in the arm, creates an immune response in the arm, and then the antibodies are released throughout the body. There's pretty clear data from some Freedom of Information data from Japan that at least for Pfizer, the spike protein doesn't stay limited in the arm that's created by the vaccine. It spreads throughout the body. Certain organs are more apt to take up the spike protein. Ovaries in women are one. It can cross the blood-brain barrier. So whether there's actually any vaccine-induced spike protein that gets into the myocardium, I don't know the answer to that question. But, those would be the kind of research topics. And it is possible somebody already knows the answer to that. I have to admit my uncertainty to the answer there.
Joe, I mean, you've been sort of a national figure when it comes to diet. I mean, I've seen you on TV shows and and, various media. I mean, for years. Do you find that your outspokenness around this is jeopardized that, has limited you in any way around that regard so far?
It's not theoretical. I've been excluded already from national TV shows. It's okay, but I have been. Absolutely. I mean, I got canceled, cancel culture. And my peers in the plant-based world don't expect to see me on panels. I am recording a podcast tonight with the few outspoken plant-based experts that are having the same conversation you and I are having. I don't really want to, but it was such a kind invitation from a very well-known author, Will Tuttle, Peace World Diet book that's been in many, many languages. But in general, I'm burning my ships behind me, as is that expression that you know so well, but it's what you do and I do. I mean, I don't want controversy. I don't want to take risk. I don't want hospital boards to, question my posts. And I can defend every one of them, but these aren't normal times. We are very in McCarthyism-like times, and one has to wonder, when is the witch hunt really going to begin? So, you have to ask yourself, what are you made of? And what's your purpose here? And I don't believe in people being sheep. I know you don't believe in people being sheep. And it's painful, dangerous, can be expensive. I expect my friend, Dr. Peter McCullough, will have every initial ripped off his name except MD, because he's got many, and journal editorships, and he knows it, but he's going down with the fight, and hopefully won't, but it's going to cost him a lot of money for legal battles and all. And, none of us invite that, but at the end of the day, what are you going to say at your eulogy? I decided not to speak up. I'd rather I was uninformed, but once you become informed, you got to make a personal decision.
Yeah, and again, I applaud your courage in this, and I've seen this. If nothing more, I was jaded a few years ago, and it's become more so, and I just, hopefully more and more physicians, hopefully we'll end up on the right side of this. We know that the people that burned the books and censored have never been the good guys historically, and I think that the historical precedence for this sort of stuff is. I mean, for anybody that has any inkling of history can see where this stuff can potentially go, because it's, it starts here, but where will it go next? I mean, it'll be, if there's a cow.
Respect for you there, Doc, not only for your
Yeah,
stance, but also for your Afghanistan tours and all that, destruction of everything you risked your life for, and it went down the toilet. But we'll do the next podcast on solving that part of the world.
Well, I mean, perhaps we'll split a meal. I'll have the carnivore side. You can have the vegan side and the gulag together sometime. We'll see.
I'll eat whatever the cow ate. You eat the cow, and we'll have good conversation.
There you go. That sounds good. Well, Joel, what do you have coming up in because I think you've earned, some people that appreciate you that may not before, just on what you're doing here. Where can people go on your social media or find out more about, heart disease? Or, I mean, I don't think you're going to convert too many people to plant-based diets in this community, but, they'd love to hear about, more of your thoughts on.
Majority of my patients are healthy eaters of a broad spectrum. I don't require people drop their steak at the door. They know it's an option to be plant-based, and many choose somewhere in the Mediterranean world. And I have paleo and keto and carnivore patients, and I don't chase them out of the practice. I just don't want them at McDonald's and Wendy's. So, my main passion is early heart disease detection and early heart disease reversal, and everybody benefits. You've had your calcium score, your labs. I've posted my calcium scores in this more advanced thing called Clearly CT angiography, but I'm at drjoelkahn.com, DrJoelKahn.com. And it's a vibrant practice. I have licenses in many, many, many states in the United States. You're in the state of Wyoming. Yeah, I can go hide in Idaho and Wyoming now and practice medicine in my boxer shorts with a laptop. What part of state of Washington are you?
I'm in a town called Snohomish, which is it's about 30 miles northeast of Seattle. It's kind of in the rural. We're sitting on 5 acres in the middle of
Beautiful.
the secluded area.
Beautiful.
Uh, so it's quite nice. So anyway, Joel, well, let's do this again sometime. Like I said, like I said, I have to say that I'm happy for what you're doing with regard to this, and I think it does show someone's true colors at the end of the day when pressed. And I think there's a lot of people I'm quite disappointed in, just to say it mildly, that they're not being more vocal about this stuff. But thanks for doing so, and thanks for doing this on Sunday again. Appreciate it.
And just tell me, Shawn, where's this posted? Because I'd be happy to answer some of the questions in the chat. And I don't know, I might just do it right now, but I can do it certainly. Is it going to show up on YouTube or your channel?
It'll be on our Revero podcast channel.
Okay.
It'll be in there. I don't know if there's I'm looking through the questions here, and I think the one is asking about, and you kind of mentioned this earlier, is about a young male that has myocarditis. Does it have an impact later in life? And you said there's going to be some scarring, and it could result in, something down the road. And then somebody's asking about nitric oxide as a supplement. Is that any benefit?
Well, actually, it turns out there are studies now, even in hospitalized patients, just a couple using arginine in sick hospital patients with SARS-CoV-2, and it seems to have a benefit. So take care of your arteries before you get sick. But even if you get sick, it'll work there too.
Yeah, arginine is a precursor to nitric oxide, if I'm not mistaken, correct?
Exactly. Citrulline is the other one, right?
Well, perfect. Thank you so much, Joel, and continued success. I'm following you on social media there on Twitter, and I appreciate some of the stuff you're putting out there. Thanks for all the resources. I'm sure a lot of people will utilize that, and hopefully we'll all get through this. And but I think it's gonna shift things permanently, and hopefully we can make some good out of all this at the end.
Let's keep a guest bedroom available for me if I have to leave the state on the lam. Okay.
I don't know that Washington will be a better place, but we'll see. Anyway, Joel, take care. You guys have a great day.
Bye-bye.
See everybody tomorrow. Take care, guys. Bye-bye.
Join Revero.health for a 30-day free trial to get access to live Q&A with VIP guests, social community meetings, member discounts, low-carb healthcare providers list, forum, workouts, monthly challenges, early access to podcasts, recipes, carnivore diet guide, fasting guide, shred guide, and much more.